So what do we know about cerebral vasospasm? It is known that aneurysmal subarachnoid hemorrhage, SAH, accounts for less than 5% of all strokes, but patients' outcomes remains poor, with the mortality rates up to 45% and a significant morbidity among survivors. It is mostly explained by the cerebral vasospasm, which leads to unfavorable outcome in 34% of the cases. So some definitions which will be used all along this communication: the severe refractory CVS, cerebral vasospasm, and the delayed cerebral infection. So about the CVS, it corresponds to, it happens despite the best medical treatment, and it corresponds to clinical data, digital subtraction and geography data, and ultrasound data. About clinical data, it corresponds to a persistent or worsening deficits. For the DSA data, it corresponds to a worsening of the narrowing. And for ultrasound data, it corresponds to abnormal transcranial Doppler's velocities. About the DCIN, the delayed cerebral infarction, it is visualized on the brain CT or MRI within 6 weeks after SAH, and not present on the admission CT, performed 24 or 48 hours from the admission, and not due to other cause as a iatrogenic complication, as with a surgical clipping or endovascular treatment. Historically, it was thought that DCIN was only explained by CVS, but some studies noticed that CVS is not a necessary or sufficient condition for delayed cerebral infarction. Especially Nadej and al. Found in their cohort that 62% of the delayed cerebral infarction were not explained by CVS. The rate of delayed cerebral infarction without severe vasospasm is variable in the literature. Thus, asymptomatic CVS can be found in until 99% of patients at D7 after subarachnoid hemorrhage. In the other hand, in their cohort, Verhoeven and al. Noticed that only 20% of their cohort of severe vasospasm led to delayed cerebral infarction. And we know that 24% of the delayed cerebral infarction occur without any CVS, without any cerebral vasospasm. Besides, it is admitted that treatments targeting the cerebral vasospasm are still disappointing when considering clinical outcome. So now we know that the pathogenesis of the delayed cerebral infection is hypothesized to be multifactorial. And first with the cerebral vasospasm, but it is also explained by the microthrombosis and thromboinflammation, the neuroelectric disruption with especially the spreading depolarization, inflammation with the cellular mediators, sympathetic nervous system activation, the increased intracranial pressure, and the blood-brain barrier disruption. So what about the guidelines? The only Level 1A intervention to treat cerebral vasospasm is oral nimodipine. About the endovascular management, including the mechanical angioplasty, the balloon angioplasty, and the chemical angioplasty with the intraarterial vasodilatator infusion therapy, it is only a level B for the American Heart Association guidelines, and only a level 4 according to the University of Oxford Center. Recently, Grégoire Boulouis realized meta-analysis with 62 studies, including 9,000 patients, comparing endovascular management versus the best medical treatments, and data revealed that refractory cerebral vasospasm patients treated using endovascular interventions have lower relative risk ratio of unfavorable outcome, with a relative risk ratio of 0.68. So what about the conventional angioplasty? It is called conventional because it is performed by most physicians. Proximal balloon angioplasty are performed for arteries with a diameter up to 2.5 millimeter and located proximal to the first angulation of the cerebral arteries, corresponding to the M1 and the A1 segments. About the intraarterial chemical angioplasty, it is performed with nimodipine alone or combined with milrinone, corresponding to chorotrop. In our center, intraarterial chemical angioplasty are performed with infusions for 30 minutes of 2 milligram of nimodipine, 4 milligram of chorotrop, also called milrinone in France, and 31 milliliter of serum glucose. Both have generally been shown to successfully treat vasospasm and improve neurological condition with no clear benefit from one treatment to another. To note, it is important to note that chemical angioplasty drawback is its short time effect and thus need to be repeated. So these two main approaches are used alone or combined during endovascular management. The CVS angioplasty is broadly used in acute SAH facing refractory vasospasm corresponding to a vasospasm refractory to a hypertensive treatment with vascular feeding and respect of the normovolemia. The triple H management is no more recommended. So even if these two main approaches are broadly used, their efficacy were only proved with feasible studies and retrospective meta-analysis. In 2011, Sentian and al. Reported distal angioplasty for refractory CVS, performed for arteries with a diameter of more than 1.5 millimeter and located proximal to the second angulation of the cerebral arteries. So with their cohort of 80 distal target vessels, the authors reported good efficacy, few procedural complications, and a good outcome. So distal arteries correspond to the main segments of the cerebral arteries up to the end of their second segments, represented here on the C and D picture with the red lines. More recently, Labery and al. Compared two populations with a conventional and distal angioplasty. So in the conventional arm, there is 160 patients treated with the hyperglide 410. And in the second arm, conventional plus distal angioplasty, they count 232 patients treated with Hyperform 47 or Scepter XC 412. So the differences between the two arms were significant in favor of distal angioplasty for less new angioplasty and less delayed cerebral infarction, but no difference was observed about death and outcome. So I will present you one case from our center, which is in press. We have a case series. It is about the Comaneci from Rapid Medical. The Comaneci is the first ever adjustable, fully visible remodeling device. It provides temporary assistance for coil embolization. For example, for wide neck aneurysm without limiting the blood flow. So it was thought in our center that it could be used for distal angioplasty. So this case is about a woman of 33 years old with a Fissure 4 subarachnoid hemorrhage with a brain hematoma explained by a carotid ophthalmic rupture aneurysm. This aneurysm was treated with coils. At this event, she presented a consciousness disorder due to a vasospasm of the A1 and A2 segments. As you can see on the admission DSA, you can see the aneurysm, and you can see that the A2 and A1 segment are okay, and the parenchymography is also good. At this event, you can see that the parenchymography is lacking, and you can see that there is a severe vasospasm of the A1, A2 segments. With a zoom, you can see this clearly. So we deployed a Comaneci in place. And as you can see, the parenchymography came back to normal. And as you can see, the caliber, the diameter of the target vessels also was better. These are perfusion map of the mean transit time of a CT perfusion before angioplasty and after angioplasty. You can see that the territories corresponding to the ACA segment, the anterocerebral artery segment, is very slow before angioplasty, and after angioplasty, it comes back to normal. About the follow-up MRI at day 26, it doesn't show any sign of delayed cerebral infarction in the ACA, in the left ACA segment. You can see the hematoma, which was known at admission, not corresponding to a DCIN. So now I will talk to you about a national survey, a recent one, which is also in press, about neuro-intensive care, neuroanesthesia, and endovascular management of CVS. So it is a national survey from France, performed by a trainee-led research network of anesthesia and neurologists, the GENI and the SFARGEN. So why did we perform this survey? We performed it because there are no guidelines updates since 2012. And there's a lack of consensus regarding management of neuro-ICU, neuroanesthesia, and endovascular management. So all the cities of France were performing interventional procedures answered fully to the survey, corresponding to 29 cities. So what about cities? Cities indication for it was systematically performed for 44% of the cities, of the centers, but most of the centers answered that this computed tomography was performed only if there is any cerebral vasospasm suspicion. This suspicion was based on clinical data and abnormal ultrasound Doppler. About the protocol, most of the centers answered that they performed a brain CT with no contrast, with a CTA on the arterial time and a perfusion CT. 20% of the centers answered that they only performed a non-contrast CT with a CTA, without perfusion CT. The multi-phase CT protocol was not used in this survey. 3 centers reported that they got spectral CT, but didn't use it in the diagnostic of CVS. What about the CT semiology for refractory CVS diagnostic? The narrowing of the arterial branch was described with the subjective quantitative scale: 25% of narrowing, 50% of narrowing, 75% for 24% of the centers. But most of the centers didn't use any quantitative scale to assess the narrowing. About the perfusion map, most of the centers use the mean present time, 56%, and only 42% use the Tmax and the CBF. What about the mean blood pressure target? In prevention and in post-intervention, the mean blood pressure target was for most of the centers between 100 and 120 millimeter of mercury. And it is important to notice that the mean blood pressure target was not clearly defined in the department for 26 centers. During the endovascular management, for most of the center, the mean blood pressure target was between 100 and 120 millimeter of mercury, and it was not clearly defined in their department for the 19% of the centers. So about angioplasty and the conventional one, most of the centers answered that they performed only a chemical one, and the mechanical one was discussed on a case-by-case basis. 23% of the centers answered that they systematically perform a mechanical with chemical angioplasty, and 23% responded that they performed a mechanical alone and a chemical one only on a case-by-case basis. For the distal angioplasty, only 19% of the centers in France responded that they performed it on a case-by-case basis also. So about chemical angioplasty, most of the centers used a mixture of nimodipine and chorotrop, 59% of the centers. 18% of the centers use the nimodipine alone, which is, and 15% of the centers use chorotrop alone. To infuse the drugs, syringe pump was used for most of the centers. 15% of the centers use the manual infusion, and 4% of the center use pressure infuser. About mechanical angioplasty, a non-compliant balloon was used for 30% of the centers, but most of the centers used a compliant balloon. Only 22% of the centers use the stent to treat angioplasty, to perform a mechanical angioplasty. So about anesthesia, general anesthesia was performed for 54% of the centers, and if the patient was conscious, a conscious sedation was performed for 12% of the centers, and local anesthesia for 15%. A case by case was discussed about the anesthetic modalities for 35% of the cases of the centers. Sorry. Anticoagulation during angioplasty was systematically performed for 42% of the answers, on a case-by-case basis for 23%, and never for 35%. So, in conclusion, to treat cerebral spasm and to avoid the delayed cerebral infection, we can see that about the survey and about the lack of guidelines updates since 2012, we can see that there's a very heterogeneous practice in France about CAD protocol, CT semiology, about drug therapy, about blood pressure targets, and also about endovascular treatment, including the indication, the anesthetic modalities, and about the mechanical and chemical angioplasty. So we have for now to make do with the non-update recommendations and to perform, I think, conventional angioplasty, including the mechanical and chemical angioplasty to treat the vasospasm based on the perfusion CT. So thank you for your attention.
Thank you, Dr. Jean-François, for the nice lecture. We will have discussions at the end of the session.
We move to the next speaker. I'd like to introduce Professor Laurent Pierrot, and because he busy in US now, and so we have a record of presentation about the topic acute flow diverter in the future of aneurysm treatment. Professor Laurent Pierrot is come from the Reims University Hospital. Please.
Good morning, everybody. Thank you for the very kind invitation to participate to the Vietnamese Society of Radiology and Nuclear Medicine Congress. Thank you to Professor Pham Minh Tong and Vidong Lu for inviting me. So I will discuss now the topic, are coated flow diverter the future of aneurysm treatment? So here are my disclosures. So flow diversion. Flow diversion has some strengths and some weaknesses. So it is really important to consider before discussing coated flow diverter. So when we look at the indication of flow diversion, due to its high efficacy, flow diversion is increasingly used in the endovascular management of intracranial aneurysm. At the beginning, the initial indication for flow diversion were large and giant ICA aneurysm and recanalized aneurysm. And there was a progressive extension to small ICA aneurysm, distal aneurysm, and bifurcation aneurysm. Okay, there is still some debates regarding the usefulness of flow diverter in the treatment of posterior circulation aneurysm, and also to some extent in the treatment of bifurcation aneurysm. But let's say that due to its very high efficacy, flow diversion is more and more used for the treatment of intracranial aneurysm. But in the same time, flow diversion has a main limitation, which is the need for dual antiplatelet treatment to prevent acute intrastent thrombosis, delayed intrastent thrombosis, perforators and side branches occlusion, and distal emboli, let's say to prevent thromboembolic complication. So one way to avoid dual antiplatelet therapy is to modify the surface of the flow diverter, to reduce platelet aggregation. So Phenox was creating a coating whose name is hydrophilic polymer coating, HPC. It is a glycocalyx-like surface that it's placed on the flow diverter, on which will inhibit platelet aggregation on the flow diverter. So, and it will theoretically prevent platelet aggregation. There were some tests on the bench, in animals, and it works. So now we need to have an evaluation in a clinical condition. So we have some preliminary results. I was publishing with a team of Lyon, with a team of Professor America in Lyon, preliminary evaluation of P48 MWHPC plus dual antiplatelet therapy. You see that we were recruiting 28 patients, 29 aneurysm between April 2019 and May 2020. You see the location of aneurysm is quite classical, but a lot of bifurcation aneurysm, ECOM, MCA. You see that most aneurysm were ruptured or recognized. Treatment feasibility was 100%. All patients were treated with flow diverter, P48 HPC. There were some intraoperative complications, no intraoperative rupture, but 2 thromboembolic complications, but without clinical worsening. Morbid mortality at 1 month was 0%, and you see that the rate of complete occlusion at 6 months was 87%. There was also, and it is under publication by the team of Professor Hans Senkes in Stuttgart, Germany. There was the treatment of patients with P64 MWHPC, so the coated flow diverter, plus single antiplatelet therapy in 100 patients, 128 aneurysm. The single antiplatelet therapy was prasugrel. There was a technical success in 100%. The rate of complete or near complete aneurysm occlusion at 4 months was 75%, at 9 months 88%, and there was no morbidity or no mortality. There were some intraprocedural complications, but you see that there was no thromboembolic complication or hemorrhagic complications. There were some technical problems, flow diverter foreshortening, flow diverter collapsus, and there was one ICA dissection. There were also post-procedural complications with ischemia in 4 cases in jailed MCA branches. There were some instant thrombosis in 2 cases, which is not too much, by the way, and there was a foreign body reaction in 1 case. And finally, there was delayed complication and parenchymal hemorrhage, so after 30 days in 1 patient. So you see that the rate of complication is quite acceptable and in line with what we have with bare flow diverter and dual antiplatelet therapy. So to evaluate properly the P64 MW HPC flow diverter, we have built the coating study. So Cutting is study is cutting to optimize aneurysm treatment in the new flow diverter generation. It's a European multi-center prospective randomized controlled trial comparing aneurysm treatment with a bare P64 MW flow diverter under dual antiplatelet treatment with aneurysm treatment with coated P64 MW HPC under single antiplatelet treatment. So the study design, the primary objective is to assess the safety and the efficacy of P64 MW HPC under single antiplatelet treatment compared to P64 MW bare under dual antiplatelet therapy in patients with unruptured or recanalized aneurysm. The primary hypothesis is that the treatment with coated flow diverter under single antiplatelet treatment is non-inferior to the treatment with a bare flow diverter under dual antiplatelet treatment. And the secondary hypothesis, and we can do that because we have an adaptive design of the study, is that the use of coated flow diverter P64 MW-HPC under single antiplatelet treatment is superior to the use of P64 MW bare under dual antiplatelet treatment. The primary study endpoint is quite original. It is based on the evaluation of thromboembolic complication with diffusion-weighted imaging, assessed 48 hours after the index procedure using MRI. So I just show you an example of that. You see it's a ruptured ACOM aneurysm treated in 2010, recanalization, treatment with additional coils and P48 MW HPC 3x15, final result at the end of the procedure. And you see, we always do MRI after the procedure to depict these small spots, which are the witness of some small thromboembolic complications. So it's what we are looking for in cutting study. So we have a lot of secondary study endpoints in terms of safety. Indeed, morbid mortality, the rate of neurological death or major stroke, 6 months and 1 year after the procedure, etc., etc. Very usual secondary endpoint for a flow diversion study. We have also secondary study endpoints for the efficacy of the flow diverter. We have the rate of successful device development, the rate of complete aneurysm occlusion at 6 months and 1 year, the rate of target aneurysm recurrence at 6 months and 1 year, the rate of aneurysm retreatment at 6 months and 1 year, the rate of intrastent stenosis or thrombosis at 6 months and 1 year, and also the mean length of hospital stay after the procedure. The number of patients expected in a cutting study is 200 patients max, 100 per randomization arm. We will have a maximum of 25 centers in 6 countries: France, Germany, Italy, United Kingdom, and Switzerland and Israel. So the study timelines. The plain enrollment period per site is 12 months. The plain study duration is 36 months. You know, the first patient in was supposed to be Q3 2021, and it was the case. And the last patient out is supposed to be in Q1 2024. So there will be an interim report at Q3 2022 after 50% enrollment. And enrollment effectively started in August 2021 in France, in my center, by the way. So inclusion-exclusion criteria. Okay, the study is dedicated to saccular, unruptured, or recanalized intracranial aneurysm. In case of ruptured aneurysm, you can include the patient if, you know, the rupture occurred more than 30 days before the index procedure. the patient is intended to be treated for only one target aneurysm, except for segmental disease. Segmental disease is when you have several aneurysms on the same arterial segment. Indeed, we have some inclusion criteria regarding the size of the parent artery, which has to be between 1.5 and 5 millimeter. We have also, we need indeed to have a written informed consent, and we only include patients with a clinical good shape, with a good clinical shape before the procedure, with the MRS inferior or equal to 2. Exclusion criteria. One important exclusion criteria is that patients who are currently under long-lasting antiplatelet or anticoagulation medication are excluded because it can change the results. Indeed, if for patients who had recent surgery, recent intracranial hemorrhage, recent subarachnoid hemorrhage, recent is in the last 30 days, they have to be excluded. And indeed, if the target aneurysm was previously treated with a stent or a flow diverter, they have to be excluded. Also, as usual, we are excluding blister-like aneurysm, fusiform aneurysm, dissecting aneurysm, or aneurysm associated with brain arteriovenous malformation. And we have also a contraindication in case of stenting of the ipsilateral carotid artery at the level of at the cervical level. So, what is the process for randomization? As soon as we have assessed the eligibility criteria and we have the informed consent, we will randomize. It is a 1.1 1-to-1 randomization. So you can be randomized P64 MWHPC with SSPT, only prasugrel or ticagrelor. And if you are in this arm, you will have a single antiplatelet treatment with one of these two medications for 6 months. And thereafter, you will stop the medication after 6 months, and you will continue with aspirin. In the second arm, P64MW, we will use DAPT, dual antiplatelet treatment, prasugrel or ticagrelor plus aspirin. You will have this treatment for 6 months, and after 6 months, you will stop prasugrel or ticagrelor and continue for aspirin for at least 6 months. So, management of the trial, the steering committee, I am the PI, Professor Cognard and Spell and Dr. Lamine in UK are the other members of the steering committee. We have independent expert groups. We have a DMC group with Jens Filler, Hubert de Salle, Chiaccherini in US who is a statistician, and Schramm in Germany. We have a CEC to adjudicate neurological events with Professor Ebreto in France, Potsaris in Germany, and Fischer in Switzerland. We have a core lab, independent core lab with Clarençon, Frédéric Clarençon in France, and Engelhorn in Germany. The current status of the study, you see that enrollment started in France, not in September, but end of August. In Germany, there was a ethics committee approval in March 2022, and centers will open soon. In UK, it is, the study is submitted to the ethics committee, and we wait for final approval. And for other countries, Switzerland, Israel, and Italy, we are doing currently the regulatory process. So the current status, study status, you see that all centers in France are open. So 3 centers already enrolled patients. You see, we are treating in France 9 patients. In Lyon, there were 9 patients also included, but only 4 treated already. And in Bicêtre, in Paris, there were 8 patients with 3 patients already treated. And other centers are waiting for inclusion or opting. So here you see the enrollment status in comparison with the forecast, and you see that we exactly follow the line of expected inclusion. So in conclusion, flow diversion was of the major endovascular treatment for the management of unruptured and recanalized aneurysm due to its high efficacy. Surface modification of flow diverter will potentially decrease platelet aggregation and thromboembolic complication and permit to use SAPT. Surface modification will potentially permit the treatment of ruptured aneurysm. So cutting is the first multi-center RCT comparing bare flow diverter plus dual antiplatelet treatment with coated flow diverter, P64 MWHPC with single antiplatelet therapy. Thank you for your attention.
Thank you very much for very nice presentation of Professor Laurent Pierrot. And for next topic, I'd like to introduce Professor René Chapeau. He's a very famous speaker. In previous 2006, he's a professor and head of neurology University Hospital of Limoges, France. And after from the 2007, he's a head of department and center of neurology and intracranial endovascular therapy in Clark Hospital Essen in Germany. Now he talked to us about the topic of update on AVM treatment. So please.
Hello, it's a real pleasure for me to be part of the meeting and to have the opportunity to give you some insights in the treatment of brain AVMs. And brain AVMs is changing a lot. Even if apparently indications are progressively shrinking, because cure after endovascular treatment of AVMs is rare, because small AVMs embolization is not required. Radiosurgery does a good job, and surgery too, because large AVMs are usually not treated, because treatment is not so easy, and the chances to obtain a cure are not so high. Unless some complications occur, AVMs, even the large ones, at some point they decompensate, they bleed, and then something is to be done. So that today, embolization is often only an adjunct before surgery or radiosurgery is being done. And those rather not good results have been confirmed and increased by Aruba. Aruba shows that unruptured AVM should not be treated because partial treatment, because not good treatment is not acceptable. And indeed, endovascular treatment is challenging because we need to use very small microcatheters in very small vessels so we can harm those vessels, because the understanding of the AVM is the key issue today. And the so-called nidus is a word that just hides our ignorance. Because it's a rare disease, how often do you have the opportunity to treat an AVM? It's difficult to feel comfortable in AVM treatment if this is not done on a very, very regular basis, meaning several times per week. And major issue is when we're facing complications. These are not minor complications. Complications related to embolization are dramatic bleeding. So what does transvenous embolization change? It changes a lot. It's a whole change in the concept of embolization, because a partial embolization where further injection of onyx is stopped because of missing of understanding is not acceptable. It's a change in treatment because we need to understand differently the angular architecture of an AVM, and that's why I don't want to talk about nidus. Nidus is a word showing that you don't know whether it's an artery or a vein, you just call it nidus. In fact, most of the AVM are veins, so that we should focus on the venous segmentation, because transvenous is a curative treatment, and because transvenous is probably the best options for AVMs that are deep located, where neither surgery or radiosurgery are good. But it still remains a high-risk procedure, because if the vein is occluded and the AVM is not completely embolized, this induces bleeding. And the fact to start to occlude the vein is something that prevents to see the rest of the AVM, which is then a major issue to be able to recognize if something is there. But transvenous and transarterial are not competing, they are complementary. And transvenous embolization is an adjunct to transarterial after significant reduction has been achieved. But in my way to proceed, because of growing importance of transvenous embolization, it changes my way now to achieve transarterial embolization. So why is it possible? Because we can navigate in the veins, and we can even navigate in most veins, but the rules of navigation are different. We cannot do a roadmap by the microcatheter. So to see the vein, we first need to bring a catheter inside the arteries, a microcatheter selectively inside the arteries in order to see the vein we want to get access to. But then we only see one vein and not all the veins around. It's also different because the veins do expand and displace more than do the arteries, so that we do not get the same quality of support as we get in the arteries, because the vessel wall of veins is much more fragile. So this means that we can only go there with the smallest and softest possible microcatheters. No way to go in with quite large material to force it. Everything which is made in the arteries where you need extra support with intermediate catheter, forget it. This is not to be achieved in veins. So why is transvenous embolization possible? Because if you diffuse with a liquid embolic agent from the arteries to the veins, then you can also diffuse from the veins to the arteries. But one of the major points is that you very often have a better access to the shunts, which means if you occlude the shunts, you will occlude the shunt without occluding a lot of normal arteries, as very often in transarterial embolization, and even more in transarterial, where some pressure cooker is achieved. You may change the name of the technique and call it plug technique. It doesn't change the fact that injection is made under high pressure, where you're more likely to occlude normal arteries. So, which patients to treat? And there is a progressive learning curve for those patients to be treated. Probably this kind of AVM where you expect bilateral embolization to cure, and here it's almost a cure, is a good candidate, because at this point the artery is very poorly accessible. You cannot navigate in that, so that any injection is very likely to occlude the pericallosal artery, and is very poorly likely to cure the AVM. So maximum risk, minimal efficient, no transarterial embolization. But if you look at the vein here is easily accessible. Now the catheter is in place here, and from there you can access to shunts, as was done here. Another situation which is a very good indication for transvenous embolization is those kind of deep located AVMs where arterial navigation is very difficult. You may see here that there are different lenticulostriate arteries. Here is the largest one, but here is one, here is a second one, here is a third one, a fifth one. This is the largest one, and maybe another here. And all this drains within one vein. And the efforts here, sorry, I'm on call. I get back immediately to you. Yeah. Hallo?
Ja, hallo Chef Krawutschke hier.
Ja.
Ich rufe an wegen einer 79-jährigen Patientin, die über die Notaufnahme gekommen ist.
Okay.
Wir hatten Zeitfenster 18:10 Uhr, also
Ja.
knapp 1,5 Stunden, hat 4 Punkte für die linke Hemisphäre und hat da einen proximalen M2-Verschluss, also Truncus inferior.
Dann sofort auf den Tisch. Ich komme. Ja, okay. Bis sofort.
Okay.
Ja, ja, danke. Tschüss. Okay, so we continue. Here is this deep AVM, which is difficult to access, where from the arteries, where we still manage with many efforts to go here through this artery, requiring a balloon, requiring a magic. This took more than 1 hour. We finally got this point, but even if we reach here, are we sure that from here we're going to include all the shunts? Are we sure that we don't block the vein without accessing to the other arteries? And this is why we navigated here a catheter through the veins, which was much more easy and less dangerous than navigation through the artery. And now the venous catheter is in place. And now some coils have been injected, some flow coils in the veins. And now we started to inject through the artery with acrylic glue. And we tried to continue, but we had reflux, we had to stop. And at this point, you still see that some arteries are patent. So what is going to happen now? Either the vein is blocked, and this may induce bleeding, or the artery thrombosis. You don't know. And if it goes into the wrong way, inducing a bleeding, this would be a nightmare in these patients. But if you have the catheter in place, we injected here a couple of drops of onyx, enabling to cure immediately. So nowadays, those kind of patients are only treated by the vein and not by the arteries. So definitely, venous access is here an additional security, and it very often appears to be like this. So which are the best candidates to be treated? Obviously, deep AVMs where there is a difficult arterial navigation, but an easy venous access, where the ischemic risk related to arterial injection is high, where then transvenous embolization carries a much lower ischemic risk, and where the expected cure rate by transarterial embolization is not so high. And in all those patients, a venous access is definitely to be preferred. Now an AVM, which is here located at the medial part of the temporal lobe, in the ambient cistern close to the posterior cerebral artery. And if you look selectively here, you only see en passant feeders alongside here the PCA, so that there is no way to access to the AVM. But look at the vein here. This vein is very well accessible from the lateral sinus, where we put 2 catheters, achieving a venous pressure cooker, allowing this to be cured, and keeping the artery patent and avoiding any ischemia. But any kind of arterial embolization here, the chances to lose the posterior cerebral artery would have been very high. So the small size of an AVM, it reduces the risk, because if you've got a small size AVM, there are less AV shunts to be treated. And whenever you occlude the vein, you must get sure that all shunts are occluded. And even if the smaller AVMs have quite often a vein which is not so large, so that navigation is not so easy, whenever the vein starts to be very large, you can expect a large amount of shunts and a potentially higher risk. That's why if you begin with transvenous, please keep it to small AVMs. So let's focus on the nidus. Nidus is something which everybody talks about when considering AVMs, which is something here where the level of understanding today is very low, because none of these drawings, this one or this one or this one, explains somehow what's going on. Or this one here, we see one red vessel that gets blue, but does it explain here how the vessels come together? The answer is unfortunately no. So neither. It's just a word hiding our ignorance. And the fact to do a partial transarterial embolization does not help, because if we reduce partially an AVM, which would be this here, we don't understand more. So by using the arterial pressure cooker, somehow we understand already a little more. Here we've got a small catheter, very important flow. So when we look at these pictures, we just can say, here's a large vessel, here's a large vein, and there are numerous shunts, or there is a macro shunt. We're afraid that we will take high concentrated glue. But if we make a plug here with these two acrylic coils, what we call the pressure cooker, which we're using since 10 years, when we do this, and if we reduce the flow, we realize that there are 1, 2, 3 very tortuous arteries arriving in this vein. And suddenly it becomes highly understandable. You can follow each of those arteries within the different loops. You can even draw them. And this is already a way to understand better, but definitely the transvenous injection has been the important way to understand how the venous segmentation is. And this ruptured AVM of the brainstem is absolutely not understandable. Even if you do here a rotational angiogram, you just see somehow a vein in the middle and you don't see more. But if you navigate with a catheter in the vein that was here, that took a lot of efforts, because always getting through the cavernous sinus is not easy. And now we can see the venous filling of the AVM. And if you follow this venous filling here, you can see the main vein, and the main vein receives some primary veins. And here are primary vein, here is another one, here is a third one, and the more we proceed, the more we can understand the ways segmentation is being achieved. So that we can draw this, and this is how I would consider AVMs are, with a main vein and primary veins arriving in this venous segmentation with lots of arteries around, which you can draw in another way. So if you compare AVMs to trees, according to the type of venous angioarchitecture, you may look at this vein here. This AVM with the different veins would rather look like this tree, or this kind of AVM here with a single vein and many primary veins all around, which would rather look like a pine tree, or these patients here with both primary veins arriving here that would rather look like this kind of tree. So this allows us to progressively introduce a stage venous embolization where we just focus on primary veins, isolately occluding the veins, occluding AVM step by step. But this, of course, requires an analysis and understanding of the venous segmentation. And as in this kind of patient here with this extensive AVM taking the whole corpus callosum, you can only understand this when we do what we call the 6D imaging, the fusion of 3D in different colors. And this enables to show how the veins are fragmented, segmented, and here it shows the inferior one to treat the anterior part. And in a second procedure, we did it on a quite similar way, looking again on the venous segmentation, on how here those veins arrive posteriorly, the blue stuff here in these veins. So the little blue vein is the one we're getting now in order to treat the posterior part of the AVM. And as step 3, then we finish the AVM and we could cure this patient. And it's not about doing pictures, but seeing how patients are. And you see here, definitely, this patient now is doing fine. And I can show you many other examples. This is a 12-year-old boy who bled 2 times, 3 transvenous embolization. This is a huge AVM of the corpus callosum with major cognitive impairment. That's why we treated her. Unfortunately, this did not bring her better. But after 6 procedures, we could cure her AVM. Here is a 49-year-old man, he bled twice. You see he's cured. This young boy bled since 15 years, 12 times, until we treated him in 3 steps, transarterial and 2 transvenous, until we could cure him. And this is still work in progress. I treated last week the anterior part. This is still to be done in the next step. And many other equivalents. She was treated here in 4 transvenous steps until we could cure her, or quite equivalent. Insula is a very good territory. This is a growing venous aneurysm. And you see that this is 2020, and after 6 embolization procedures, 3 by the arteries, 3 by the veins, we could cure him. And not only that we cure him, his mother wrote to me if it's okay for him to do skateboard a couple of weeks after his last treatment. So I asked her to send me some pictures to make sure that he was indeed so well. And here's another deep located AVM, 2 steps of transvenous to cure this patient. This kind of insular AVM, again, very good way to treat, but it takes numerous steps. Same thing here. This is a 9-year-old girl, 5 procedures, and you see here she is, and she's definitely doing fine. This guy here is a hobby pilot with this large extensive AVM. This is from the posterior circulation. This is from the anterior MCA, where the first step, second step, and third step were transarterial. And then for those remaining parts here, transvenous navigation to finish the AVMs in 2 steps. And he's good. He has no neurologic impairment, no hemianopsy. This is a patient here that after the treatment won again a couple of races. And this is here more challenging. You cannot go through all anastomosis to treat this. This requires transvenous access, partially transvenous and partially transarterial. You see here the guiding the transvenous for the last step, whereas this patient is cured. So I could show many others examples. To conclude, transvenous is a major evolution in the treatment of AVMs. There's less ischemia. There still is a hemorrhagic risk, and after 475 procedures, the risk in our experience is 5.5%. It is not easier than transarterial. It requires a lot of efforts and of understanding. So you must start with deep, small, and ruptured AVMs to go on for transvenous, because whenever you start to occlude the vein, this compartment must be completely occluded and not partially, unless there will be a complication. But we found out that progressively transvenous enables to solve most difficult AVMs that cannot be treated by surgery, while combining transarterials and transvenous by stage embolization. But this treatment requires a high level of dedication, because those treatments are associated with a higher risk. And now I'm done with the lecture. Thank you very much.
Thank you very much, and good afternoon, Professor Sapogane. I can see you and maybe from Cat Lab, right?
Absolutely.
Yeah. So we have a discussion at the end of the section. So you have one more, and we have questions at the end of the session.
Okay, but we can now discuss on the AVM if you wish to. It's okay, because the other one is ischemic stroke. So maybe we can now focus on the AVM as you prefer.
Okay, now we can discuss, no problem. So please, if you have any question, please send us on a Q&A and from the audience, please.
Professor Hane, yes. I have a question to you. Any question? No. Okay. I have a question to you. Now,